With the research design class. Okay, let me share my slides. Just a couple of minutes. Okay. Is it visible? Hello?
Yes,
Yes,
sir.
sir.
Yes, sir. Yes, sir.
Okay, fine. Okay. So we'll do very basics of the research design. And mostly we divided this class into two parts. One is for observational research design. Second is for the experimental. So today we'll be taking to the mostly the observational research designs. Okay, let's coming to the well, I'll take the one moment of privilege here. I take this opportunity, and very soon you're going to observe our Teachers' Day celebration, and I take this opportunity to, actually, I can't really thank enough, but just pay my reverence to my revered teachers, Dr. Amol Ranjan Singh, Master Ma'am, JP Sir, Sengar Sir, and the efforts has really pushed me to help to serve my students, not help to serve my students in much better way. And of course, to one teacher that I have just recently heard him in the online. It was in Ames workshop, and I think his name, I'm just forgetting. Okay, I'll be writing that name in the section later on. And I devote a lot of this presentation to him because that person has really clarified some of my concepts. Secondly, to Thanarasu sir, which I have discussed about the certain concept that I had a doubt few months back. Okay, let's begin the class. Okay, starting with this research design, this is basically all kind of designs that we'll be discussing that is comes under epidemiological studies. And what are epidemiological studies? What exactly are these epidemiological studies? What is actually epidemiology? Epidemiology is a branch of science which deals with the distribution of the disease in the population and what are the factors that is associated with, what that is influencing, and factor that is perhaps determining the distribution of this disease in the entire population. That is basically the epidemiology is all about. The way epidemiology started as a specific science basically dealt with infectious disease. But thereafter on, it started to studying many kind of conditions. Hence, this is not only now related to the studies of disease, rather, it is the distribution of any kind of health related events. Not necessarily disease. It may be quality of life, it may be happiness, it may be certain adjustment and issues. Those things are also related to that. Hence, we can say that it is a science dealing with distribution of health related events and the factor associated with or factor determining factor influencing this health related events in the population and how the information can be used for the betterment of human being. Okay. So let's come to the various kind of, what is the objectives of epidemiology. The first, obviously, it would be the studying of incidence and prevalence. What is incidence? Incidence is nothing but the number of new diseases in certain population at a given specified period of time where the population is initially free of the condition. Prevalence, you see, is the existing number of cases in a given population at a given period of a time. This is the very basic concepts, you must be all knowing it. Other is studying up about risk factors. What are the risk factors? What exactly is risk factor? Risk factor is nothing but it is kind of, prediction of, it is a prediction of some kind of untoward event. It's a prediction here, the prediction of certain disease. We are predicting what are the specific, what are the chances, what is the probability of certain health related conditions might happen. Again, all these risk factors are not necessarily causal factor. It may be causal factor, it may not be causal factor. Say, for example, with an empirical conviction, we can prove that certain kind of exposure is causing definitely this kind of outcome, disease, then we can say that's a causal factor. And those causal factor can be immediate causes, can be distant causes. And as a epidemiologist, as a kind of researcher, people are very, they get more comfortable when they're studying certain kind of immediate causes. Because studying immediate causes, they can control a lot of factors. The more the factors are appearing distant in nature, the chances of intervening variables, chances of kind of, that extraneous variable controlling all those factors, it's little bit, problematic and a challenging task. It comes really challenging task. Now, say for example, for instance, all risk factors may not be necessarily causal. Certain risk factors, now they're predicting is a specific disease, but they associate as they seems as a causal factor because they're associated with a factor that seems they associated with the factor that is mostly might be a causal factor. Say for example, it is a if I say somebody having an asthma is kind of a risk factor. It is sorry, it is kind of it's a low risk factor for developing lung cancer, or it is a protective factor for developing lung cancer. In this instance, the patient who is suffering from asthma, they only acquire this kind of property because they are not able to smoke, or they do not able to say they avoid mostly smoking. Hence, since they are associated with the less smoking, hence it may appear as a protective factor there. Hence, all the risk factors that are not causal, but they are predicting the risk of disease are known as markers. Again, repeat, those kind of risk factors uh, which definitely predict certain kind of disease condition, but they're not the causal factor. They're simply known as markers. Let's come to the prognosis. Yes, we'll be knowing how to study this prognosis later upon the time. As for the risk factor we're studying, if certain conditions are predicting certain disease, or if what are the other factors which, if it is present in the certain individual, that gives a sufficient chance, or that gives a more chance that individual will be recovering in a better manner. That is also prognosis. Natural history. One of the objectives of the epidemiology is studying this natural history. Say, for example, simply I don't want to do any kind of incidence prevalence risk factor, but simply I want to know the clinical picture of a certain disease, how it manifests in due course of time, how it happens. So that's a natural history. Lastly, yes, one of the major thing is that it also studies what are the therapeutic measures. If certain therapeutic measures are there, how it can be implemented, and what are basically outcome related to that, how it helps, or whether this is effective, whether that is efficient or not. Even those things are also the kind of objectives in the epidemiology. So for satisfying all this kind of an objectives and this for research design, certain kind of we need to follow a system, a very systematic inquiry to it. A logical model has to be there, which is required to guide us to conduct a research in order to fulfill the objectives of epidemiology, and that's research design. A logical model has to be required because there's a very systematic inquiry has to be done to fulfill this kind of objectives that we put onto that, and how that has to be progressed. That is a research design. Again, the first step of formulating a great research design or appropriate research design depends upon our research question. Selection of research design depends on the question that we want to answer. So what is the question is the research question. What is the question that we're trying to attempt to answer? So that is very parsimonious for getting, until unless we're not framing our research questions very appropriately, it will be very difficult to know what specific design we are looking to it. So selection of research design has to do a lot to kind of research questions you do have. Now, so what is that research question? Basically, we won't take much time on that. So first, what we do in kind of mostly research, we select a certain kind of a broad topic and we go to that broad topic, and we do systematic reviews, to ask some other individual who are experienced enough. Then we try to find what are kind of gaps in the literature, whether things are known or unknown. If it is unknown, whether that is not ambiguous in nature. If that is ambiguous in nature, what can be done? And simply also it can be aimed at, okay, things are known, things are not ambiguous, but I want to see the replication of those studies, whether those studies after having a sufficient replication gives the same kind of result or not. So all it depends upon the research questions. So what are those research questions can be? Say for example, in this example, be taking about two variables, exposure, and second is the outcome. These are the two things we must be very clear about it when we're going. So basically, when we try to any kind of study, our research question mostly will consist of three aspects. First, variable related to the exposure, variable related to the outcome, and who are the target participants. Sorry, who are the target population for whom we are targeting this, our research study is all about. Say for example, here we're taking two very basic, and right now this is happening a lot, research related to this, role of meditative practices in sorry, in academic achievement, or you can say performance achievement, professional academic achievement. So better let's at academic achievement. Exposure is kind of, that is what we're thinking that this can lead to that, or this can happen certain role in academic achievement, outcome measures that we're interested to see. So this is the two examples that we'll be talking about. So how these two things we can study, and what are the possible questions may be related to that, and what kind of questions can give to what kind of specific design that we'll be going through now. Say for example, about these two variables, I was just want to describe the phenomenon. Say for example, do the individuals who are having higher academic achievement, whether they do any kind of meditative practices? If they do certain meditative practices, what kind of meditative practices they do? Is there any relationship between meditative practices and academic achievement? And what one does during the meditation at all, after all? So this is nothing but I'm just trying to describe the phenomenon. Here I'm not comparing this thing with other kind of effect, but simply I'm describing this phenomenon. Second is can be analytical in nature. Say for example, here, do people with higher academic grades are better able to meditate than people with lesser academic grades? So here what I'm doing is that I'm trying to compare the people who are having higher academic grades and another bunch of peoples. A descriptive that in the previous part, you're not comparing anything. I'm just trying to describe the phenomenon. But here I'm comparing. A comparator result is there. Do people with higher academic grades are better able to meditate than people with the lesser academic grades? The third kind of it might be the questions related to the cause effect. Does increasing this meditative practices leads to a better academic grades or achievement, or vice versa? Say for if a person who is better in academics can do a better meditation, or meditative exercises the people can do. Here I'm trying to demonstrate the cause and effect. So it all depends upon the question. If the questions are mostly of descriptive in nature, we'll do specific design, we'll choose a specific research design. If the questions are analytical in nature, we'll do specific design. If the questions are related to the cause and effect, we'll do specific designs. So while we're trying to describe this phenomenon in the descriptive studies, basically there we're trying to generate certain hypotheses. In analytical designs, we're trying to test certain hypotheses. In cause and effect, we're trying to prove certain hypotheses. Yes, I'll be explaining all these things in details, but this is just kind of overview about it. Now let's come to classification of the research design. What the research design? Sorry, just let me. Okay, the main point, the differentiation, obviously, at a broader context, the research design can be divided in two ways. One is quantitative, second is qualitative. So basically today we're doing the quantitative part. In the quantitative part, the main differentiation between experimental and observational study is that it lies on the question whether the research assigned the exposure. Here, the exposure is not only kind of therapeutic agent, it may be any characteristics that we want to study, try to understand. It may be any characteristics that we think that if the person is having that characteristic, some result, something will happen. So here the exposure is meant in a broader way, not only interventional way, but also having certain kind of characteristics that we think that can yield to certain kind of outcome. And here, we need to be very clear about this aspect, whether the research assigned the exposure. Say for I'm giving certain kind of exposure, certain kind of cognitive behavior therapy or any kind of therapy, whether in that study, I have, me being the researcher, I have done any kind of treatment to the patient. If not given, have I tried manipulated the experiment, whether I have increased the level or decreased the level, increased the session, decreased the session, modified the session, being the researcher. The two things. If it is yes, yes, I have done, I have manipulated the intervention, I have either given or added or subtracted certain kind of things there, then that is experimental. If no, yes, the researcher has not done anything, he's just only observing the phenomenon, what is there, then that is observational. Certain questions arises here. Then whether all the interventional studies will be related to the experimental, and in the observational there will be no intervention. It's not like that. The difference is that as a researcher, what I did there, if I actually took part in the intervention, I added or modified something just to know, just to see my hypothesis, there to check my hypothesis, to prove my hypothesis, then that, if I have done, that is experimental. If somebody have only observed it, have not done. So in the observation, even though it can be intervention oriented, but provided the researcher has not taken part in that, is not manipulating the exposure to see the outcomes there. So that is observational. So basically now we'll first, in this class, we will focus on the kind of observational research designs. So what are the classification of the observational research designs? Again, as I told, whether there is a comparison group is there or not. A control group, as in a way we say that, whether there is a comparative group is there or not. If there is no comparison group, I just want to describe the phenomenon. So that is a descriptive study. And it can be case report as well as a cross-sectional. They're the two very popular forms of descriptive studies. Here, the basic differences is that here there is no comparison group is there. Another form, yes, there is a certain comparison group is there. Then that would be analytical in nature. So those three basic forms are cohort, case control, and cross-sectional. Now you'll be telling, sir, even the cross-sectional it is in the analytical, even the cross-sectional there is in descriptive. The main difference, as I tell, is this, whether a comparison group is there or not. Say for in a certain cross-sectional study, there is no comparison group. Basically, that is a descriptive. If there is a comparison group, then that comes under analytical. Similarly, in cohort studies, certain cohort studies, now when we say cohort studies, yes, almost we mean it analytical, but in certain times, there will be no comparison group. So that will be considered as a descriptive design. I'll be describing those stuffs in a few minutes. Yes, that is the basic difference, whether a comparison group is there or not. On the basis of this, classifications have been done. Let's come to the descriptive studies. So as I told, the descriptive study where there is no comparison group. When we do certain kind of descriptive study, basically, as I told, most of the descriptive study, it is done when not much information is there related to the either to the exposure or to the outcome, and very little is known about the occurrence or determinants of health condition. So here, basically, we try to generate certain hypotheses, which those hypotheses would be tested in the analytical methods. Here, we're not testing any kind of hypothesis. Rather, we're interested to generate certain kind of hypothesis. Hmm. Basically, two divisions are there: case reports and cross-sectional. As the case reports, the name suggests, and we might have been read about many case reports during in our academic degrees. So basically, case reports are those kind of descriptive study, which, say for example, I'll give a certain example, then I'll come to the main description. Say for Vikrant, was there in a certain hospital, he's working in a certain hospital, and he saw a very different kind of, while going to his clinic or while going to the ward, he saw a very different manifestation of certain symptoms in a particular patient. And those kind of manifestation he has not seen with that kind of patient having the similar diagnosis. And that was very unique for him, and that was very unusual considering the background. He has studied about the condition and he has known about the condition. Hmm. So what he did, he asked the uh, nurse there what kind of medication he has taken, what has happened in the last 24 hours. Then he might got of information during while attending some kind of group therapy. He listened something, and after that, he's doing all this kind of behavior. Same stuff he also kept on observing in 2 3 patients. And what similarity he found? He found that while attending certain group therapy session, something was done. After that, these 3 4 people are behaving in that way. So here he might create kind of an hypothesis, maybe some action related to the group therapy manifested to certain kind of things. So here in this process in the case report, he is trying to not compare anything, rather just trying to record everything in systematically as he has seen. He's trying to present a very complete picture as much as possible. Okay, now to give a very simple example of this case report, though it may not be that academic oriented, but to make in a very easier understanding. Say for example, again, Ben Ebenezer, he belonging from this part of country, northeast Mizoram. Assume that he has never taken any kind of South Indian food. One fine day, he went to, say, home of Kalyani in Tamil Nadu, and she served him certain South Indian dish. And while eating that, he felt very happy. It was very it was very nice experience for him. And then he kept on thinking about what was that, specific ingredients is giving such kind of great taste. Whether this kind of chutney, whether tapioca, or whether some other masala is there. So then he made a formulate a certain kind of, yes, all these things I have written previously, these ingredients, maybe this chutney I have not written. Maybe this addition of chutney is giving this taste to this kind of dish that I have that he has been provided. So yes, but now after that he called, say for another individual, to Bikrant or to Naina, as they both are from belonging to origin from South India. Well, then he explained to them, I had a fabulous food, but I just want to know to share whether this Kalyani has given me the right thing or not. Now I liked it, but I want to compare it. So this both of the people will call him, tell him, no, see, we are very far, we cannot come to Tamil Nadu just to because that you want to have a different food. It's okay. You have this experience and best of luck. So that poor guy there, he could not do any kind of comparison. So whatever he got in that dish, he clearly narrated, described, and put in the notepad. After that, he was very satisfied with the food. So when he came back to Mizoram, so and he thought of that, okay, I'll do this kind of dish preparation that I ate over her at her place. So I'll do some kind of experimentation. What is experimentation? So whatever the things are there, I'll try to, or I'll take the recipes, I'll add some more ingredients, I'll decrease some ingredients, and to reach a conclusion, what specific combination is giving the great taste and the different taste. So until unless he's not doing that, he may not have bring to any kind of conclusion whether what specific ingredients are actually giving that great taste. So if he's having only the experience of the food given by Kalyani, So basically, all the description he's doing is a case report. Try to understand. This is very layman way, but it's something like that. Case report are deserved for any kind of observation that is unique and is very unusual, and where the individual tries to present as complete picture as possible. Yes, and now saying in terms of publication wise, if you see the case report, that may not have that great stance, that empirical no, support as for other kind of research design, but nonetheless this case report, if it is done in a proper manner, and if we have reported something unique and unusually appearance, then it also very fabulous in nature. One of the example that I'll quote this studies done in 1980-81 in Los Angeles. Basically, that is related to the AIDS. What happened is that in that study, it was published in, that is, the journal name is, yes, Morbidity and Mortality Weekly Report, where you know five they reported five homosexual individuals. They complained of pneumocystis, and basically they could not find any reasons. But what the link they got is that all those five people are homosexual in nature, and they derived might be something, this sexual intercourse related to the homosexuality might have contributing certain kind of problem to them, and that only gave certain kind of knowledge related to the individual. It actually given hint hypothesis that might be this kind of nature of sexuality or something unprotected sex might have caused certain kind of problem, and it led to the rise of knowledge of epidemic at that time related to the AIDS in Los Angeles. This is just a quote of that article, where it is written: the occurrence of pneumocystosis in these five previously healthy individuals without a clinically apparent underlying immunodeficiency is unusual. The fact that these patients were all homosexual suggests an association between some aspect of a homosexual lifestyle or disease occurring through sexual contact in this population. Dot, dot, dot. So this is, even if a case report is done in a very perfect manner, it can have a great results. Let's come to the second part, cross-sectional, another part of descriptive study. Mostly I'll be dealing with this kind of cross-sectional study when I'll do an analytical study. I'll explain there how the cross-sectional can be descriptive and how the cross-sectional can be analytic. We'll do this later on. Now let's come to the analytical designs. Basically, under this cohort, case control and cross-sectional are there. Say for a certain, the first part is cohort study. And when this analytical design are done, if there is certain kind of a convincing information, certain kind of descriptive studies on certain topic has already been done, certain hypothesis has been generated, and those hypotheses we want to now test it. So this is basically where the analytical studies comes into the picture. As I told, all analytical studies need to have a comparative group. If there is a comparative group, then we'll say that's an analytical observational research design. So let's come to the very basic and the most important observational research design, that is cohort study. What basically are cohorts? Cohorts are nothing but the group of peoples. The group of peoples who are, and all this group of people having certain common characteristics. They are sharing certain common characteristics in between them. So say for example, might be 15 individuals are there. All these 15 individuals, they are common at least in terms of what they have received in the last 1 year. That might be cognitive behavior therapy. Cohort is simply the group of people sharing certain common exposure or common characteristics that the individual, the researcher, wants to study. Again, that exposure might be interventional in nature or certain characteristics that they do have in common. That is the cohort. Then what happens? And all those cohort are looked into a future considerable period of time. And basically, since this is an analytical study design, here the researcher will be trying to do draw two kind of groups. One is exposed and second is the reference cohort. As the name suggests, exposed cohort are those kind of group where the common element in between them is that they are sharing certain one thing, and that one thing, that is a point of study. Second is the reference cohort. Here, the reference cohort are those kind of cohort, those kind of the group of peoples who are very similar to the exposed group, but they do not have history of exposure to those things. So, for example, if I am studying, coming to the example of meditation, uh, I'll be making one cohort where, say, of 30 peoples, and those 30 peoples are index cohort. Are those people are in the history they have exposed to meditative practices, and for that comparison, I'll take another group that will be reference cohort. Are those 30 peoples who have not been exposed, or they don't have any exposure to the meditation at a given period of a time. So that is the reference cohort. And why this cohort is being done? If we want to prove certain something like that, uh, if meditative practices gives rise to a better academic achievement or professional achievement, then why not to do an experimental study? Yes, experimental studies are obviously the first thought of any kind of empirical inquiry. But sometimes what happens is that, it is very unethical for the researcher, if for his own study only he is exposing certain individual to a possible risk factor so that he can know the etiology of certain disease. So this is very unethical nature. He cannot intentionally expose to somebody to radiation so that he wants to know the etiology behind it, how that is causing, what kind of outcomes that is causing. But what happens, knowingly or unknowingly, we individuals, we human beings, exposed to certain kind of harmful factors. It maybe kind of sedentary lifestyle, maybe smoking, maybe very non-vegan foods. So whatever, knowingly or unknowingly, we do expose our to various kind of certain harmful factors, and those factors, intentionally or non-intentionally, or you know by choice or by force, causes certain kind of health conditions to us. So what happens in that point of the time, that here the researcher takes those individuals where the exposure has already been done. And here he doesn't have that, ethics issue, exposing to a person to certain kind of threatening condition or certain kind of protective condition, to name that. So basically it is related to ethics. But apart from the ethics, certain pragmatic issues also be there. And what are those pragmatic issues that I'll be discussing when I'll come to various subtypes of cohort study. So basically, when we choose a cohort design, one way is not, well, we cannot give unethical exposure to certain individual that we know that may causing certain risks to that individual. Again, as I said, cohort study, mostly that is analytical nature, but also can be descriptive. How it can be descriptive? Say, for example, I'll be taking a certain group of individual. They have been exposed to certain kind of condition in the past, that is exposure for me. So then I'll be following those groups for a certain period of a time, say for 15, 20 years, just to know what is the clinical picture of those individuals. What is manifestation taking place in that individual. I'm not describing anything. I'm not analyzing. I'm not comparing with other individuals, but simply I am kind of, giving kind of, just want to the natural history of the disease. Then that is a descriptive. But mostly when you do cohort study, mostly that is analytical. We compare with certain individual. We compare the exposed group with the reference group. Reference are those where obviously the exposure was not there. What are the few famous examples of this cohort study in our one study, that is Stanford marshmallow study. And this is this study, I'm so obsessed about this study that almost I find a way to quote this study in many of my lectures. And what happened in the Stanford marshmallow experiment, I must be aware about the study. What happened during the 1972, Walter Mischel did certain kind of experimentation, not experimentation per se, but yes, certain kind of research. where uh, the group of researchers gave certain kind of marshmallow. There were two conditions were there. Uh, One condition, and those were done to the group of childrens. Yes, in one group, not one group, sorry, in one condition is that either they will be receiving a marshmallow. Marshmallow is Americans, confectionery, sweet something substance. Understand something like rasgulla. They were given two choices. First, one immediate choice, small reward that either they'll be getting one marshmallow. That is the first choice. If you and second choice, they also can get two marshmallows if they wait for a few period of few minutes, and during that minute the researcher will go outside of the room, then will come back. And if they wait for the researcher till he's arriving back to the place, if he's not eaten that marshmallow, then he will given two marshmallows. And obviously this marshmallow is for only for the children. That was confidence was given to them. Either if he's taking immediately, then he won't be getting the second one. If he's waiting for the researcher to come back, till then he's not eaten those marshmallow, then he'll be getting two marshmallows. Basically, this is a delayed gratification studies. A follow-up studies were done after 15, 20 years from that event, and the peoples are divided. The children are divided in two groups: those who attend suddenly and those who waited for the second marshmallow. So that is kind of a follow-up studies they did. Then obviously the result was that those people are able to wait for the second, uh, you know, to for the researchers to come back so that they'll get second marshmallow, two marshmallow at a time. And those individual, depicted a significant, better, you know, IQ scores, SAT scores, educational scores, marital satisfaction scores, professional achievement scores after 15, 20 years of that, you know, time period. So that is one of the very famous cohort study. Secondly, it is related to that. Obviously, you must be knowing Framingham heart study. In the most of the books that you'll be hearing, the two examples are there: smoking and lung cancer. Smoking and lung cancer. That is something is related to Framingham heart study. So I'll be taking the leaf from that, study, and I'll be explaining for that, cohort purposes, to explain you the differences between the subtypes of various cohort studies. Let's come to the types of cohort study. The first is prospective cohort study. Again, as I told, here two groups has to be taken. First, those who are exposed. Second, those who are not exposed. Say for today, at this time, 2021, I'll divide the group into two peoples. In exposed, I'll take certain number of group of peoples, maybe 20, 30. In the reference group, I'll also certain kind of groups. So those who are not, they are not taking any kind of smokings. In the past, in the history, they have not taken any kind of smoking. So here I want to compare what is the chances of the lung cancer. What is the chances of the lung cancer happening in the future? So what will happen? I'll wait for 15 years, then I'll follow the individuals for 15 years. In 2015, just a minute. Okay, say for till 2036, then I'll compare the outcome there. Within the exposed group, how many have developed lung cancer, and in the non-exposed group, how many people have developed lung cancer. So this is basically why I'll wait 15 years. See, the wait period is something that is related to the latency period of a certain disease. Say for example, we must be knowing that if we must there has to be a sufficient time has to be given to the individual so that the risk factor clearly develops into certain kind of outcome factors. Let's say for example, cannot take that somebody is taking smoking. After 1 year we'll do the comparison. So this is not a healthy way. Within that 1 year, hardly people will get lung cancer. So the weighting has to be done as per the previous knowledges on the time period, or the how the latency period, how the expectancy of developing certain the outcome. Till that we have to wait for it. Yes, as the suggest, what are the advantages related to this kind of study? incidence. We can calculate the incidence here. I'll be explaining how you will calculate the incidence in this kind of studies. And here, temporal sequences also can be studied. What is a temporal sequence? See, here, as in 2021, I'm taking two groups: those who are being exposed to smoking, and those who are not exposed to the smoking. So here, the exposure, something I know very well. And one condition is that during the selection of the subjects and the exposure and non-exposure group, here the outcome has not to be there. If somebody is 2020 is already having a lung cancer, there is no point of including the individual in the cohort study, in the prospective study. Here we're interested to see how the smoking will leads to what kind of outcomes in the future. So here we clearly, there is a temporal relationship. Yes, this outcome was there, then after, sorry, this exposure was there, then after following up, we are able to see the outcomes. There's a temporal sequence is there. Here we start with, again to summarize, we start with the exposure here, not with the outcome. We see the outcome in the future. And this is can be also done for the rare exposure. Say for examples, and certain kind of exposures are very rarely found, and not much kind of is there in the population. Prospective studies are always good for that, but this is not good for rare diseases. I'll explain later on why it is not good for rare diseases. What is the disadvantages related to it? Obviously, it's very you can guess the disadvantages. Somebody has to wait for 15 years in this example to see the outcomes. What happens during this 15 years? Obviously, many data loss might be there, and it might be highly difficulty to follow all the subjects for the 15 period of a time. Also, a lot of money is required for the assessment. Lot of man resources are required to follow the individuals for 10-15 years. So these are certain kind of disadvantages related to the prospective cohort study. So coming again to the prospective cohort study, these three things, certain kind of we have to be very serious related to the how what cohorts are there, what is the characteristics of the cohorts in our study. We need to define the exposure and we need to define the outcome there. Say for example, let's come to the defining the cohorts, and all the cohorts that we're selecting in the both group, exposed group and the reference group, they have to be the representative of the population. Second is there have to be enough number of subjects. Why enough number of subjects? See, basically here we're trying to see, say that example, a disease is taking 15 years to manifest from the exposure to outcome, for example. So there has to be a certain number of, years spent, a certain number of time should be given the disease to manifest. And most importantly, the subject has to be more in number because it is related to the, say for example, most of the incidence of certain disease are 5%, 10%, 7%, 8%. So out of the 100, only 5, 7, 8 people are having certain stuff. So here, the more number of subjects are there, better is for the prediction here. Hence, for this reason, presence of if prospective cohort study are not suitable for, it is not suitable for the people if for the disease which is having low incidence in nature. To make this point clarify, I'll give a very kind of symbolic example. Say for that I'll go to a top university, and I'm interested to select very intellectual students or students having very genius intelligence. I'll go to, say, for very well-known, well-acclaimed university, maybe Harvard, Cambridge. So out of the 100, chances are there, I'll find many students having this genius and high intelligence. There's a high chances is there. But if I go to, say, for example, of an university that is not recognized by UGC, it has been tested. I'm interested to take 10 geniuses from that institution. And to find the 10 geniuses, what I have to do? I have to take more samples to select those 10 geniuses. To find the 10 geniuses within that sample, Practically, I need to take number of samples and to from that college. But if I take somewhere from like top-notch university, even if I take few samples, there are high chances that you know will get 5 or 10 minimum that I am anticipating. Similarly, and it's a kind of a metaphorical manner. Similarly, if a disease that I know that is very rarely found, and in order to study that rare diseases, I have to take a huge number of samples there. So that chances is there to find that rarity. But again, any kind of study design which will take very long in period, and taking for rare diseases, I have to take maybe high number of subjects. There, the cohort study will be very difficult to implement. It's very time taking in nature and it's costlier in nature. That is the main reason which cohort studies are not suitable for disease having rare incidence, having low incidence. Yes, third, one of the critical point related to this cohort selection, the reference cohort must be similar with the exposed cohort in all the conditions except the exposure status. And what I mean to say, the background variables, age, sex, all everything, occupation status, all the things as much as proximity has to be there between the two groups. Only the differences is there has to be the presence of exposure in the between the exposure and non-exposed group. Apart from this, they must be similar in all conditions. Define exposure. Try to define the exposure. Say, for example, as we go for the example that I gave you, want to study the association between meditative practices and high intellectual, or say for academic grades. So what do you mean by exposure here? Say for how many minutes you would be devoting so to that condition that you'll be giving the status that the person is now exposed or the person is not exposed. Will you include those individual? Just a minute. Just a minute. Just a minute.
Sir,
Okay.
Narendra, sir.
Yes.
Sir,
Yes.
Abhipsha had messaged in the group telling that she is in the waiting room, sir.
Yeah. I added. I added.
Oh, okay, sir.
Added.
Okay,
Just
thank you, sir.
okay. Fine.
Got it, sir. Thank
Okay.
you.
Okay. Okay. Yeah. Okay. So, what exactly is the exposure here? Say, for example, will you include that individual? Say, for in the example of meditative practices, those who have done just most of like us, before the result is out, before 2 3 days, results are. I mean, the results supposed to be out. We go to temple and do certain meditation. Will you include those people? Or say for what is the characteristics of the to determine whether the person has been exposed or not, what length of minutes he has done meditation, so that he'll be defined that he'll be included in the exposure, or he'll be not included in the exposure group. So those things definition has to be very clear. Until unless it is not that clear, it will be over representativeness of exposure, or it will be under representativeness of the exposure. What exactly is the criteria to define the person is exposed or not? That has to be clearly defined. Hmm. Again, defining the outcome. So, for example, what if I say academic achievement? It may be very vague word. What exactly you mean by academic achievement? By what scores you are going to judge the academic achievement? Uh, Whether you take the professional achievement, you will go to certain scores. What on basis of what you will determine the academic achievement? So that has to be clearly defined before, and until unless these things are not clearly defined, it will be creating a huge problem. Now let's come to the measures of association related to the cohort study. Excuse me. As I told, see, cohort study, here we can calculate the incidence. And what is the incidence? Incidence is the number of people, number of new cases at a specified period of a time in a specified given population, which is initially not having certain disease. It's not having that condition. Say, for example, we studied this group of people for a considerable period of a time. Then, how many people in that particular group developed the condition? So, in that way, we can calculate the incidence. It is the absolute risk. Secondly, the mostly have underlined this term relative risk. Basically, mostly when we do cohort studies, we are more or less trying to calculate or giving more or less emphasis on finding the relative risk. And what is the relative risk? It is also known as risk ratio. Ratio between what? This is ratio between two absolute risks. So during the cohort study, we are finding two incidences. Incidence, first, incidence of certain disease in exposed group. Another, incidence of disease in non-exposed group. I repeat, incidence of the disease in the exposed group and incidence of the disease in the non-exposed group. So that is basically here the two incidences are there. What is relative risk? Simply it is a ratio between both of them. To tell in the formula, incidence of disease in the exposed divided by incidence of the disease in the non-exposed group. That is a relative risk. If somebody say what is the interpretation of relative risk, this is very, very important. Try to focus a little more. Say for example, I'll tell 5 is the relative risk after my calculation. Basically, the interpretation of this relative risk is that what times more likely the exposed individual more likely to develop certain condition or this disease of interest in comparison to the people who are not exposed to this certain condition. Say, for example, if the score is coming 5, then I can interpret the result in this way. 5 times the exposed people are likely to develop lung cancer as compared to the people who are not smoking, or 5 times the individuals who smoke are likely to develop lung cancer in comparison to the people who are not smoking. This is the interpretation of relative risk. Now let's come to the attributable risk. This is also known as risk difference. What is attributable risk? This is something, what you say that, absolute effect of certain kind of risk factor. It would say, what is the additional risk factor of a certain exposure? I'll give you example, then you'll know the interpretation of it. Say, for example, I'll tell the formula so that you will understand the attributable risk. This is also known as risk difference. As I told, we'll have two incidences here. Incidence of disease in the exposed group and incidence of disease in the non-exposed group. In the ratio, we're dividing both. In attributable risk, the formula is incidence of the disease in the exposed group minus incidence of the disease in the non-exposed group, divided by incidence of the disease in the exposed group into 100. This might be appears little complicated, but let's first take the first two important concepts in the attributable risk. This is known as risk difference. Why the risk difference? The difference between the two incidences. Incidence of the people in the exposed, incidence of the disease in the exposed group minus incidence of the disease in the non-exposed group. If you can understand in this previous condition, say, let's go back to this example. Okay. Here in this example, in the 2021-2036, we developed, we able to see certain kind of lung cancer, say for maybe 70, maybe 80 something kind of people develop lung cancer out of 100. And in the non-smokers group, where they have not any kind of, they are not smoking, even out of 100, they got 20. In the exposed group, say for example, they developed 80, and in the non-smokers group, it becomes 20. So here the formula, actually the formula 80 minus 20, that is 60. That is the attributable risk. What is the interpretation of that? We'll come to that, explain to you. The main concept, this is known as, this is the absolute kind of, effect of a certain incidences, certain risk factor here. So after minusing all this stuff, if you can remind the concept I told about what is markers and what is risk factor, what is the differentiate, what is the risk factor and what risk factor are termed as marker. All risk factors are not causal factor. What are and if, say for example, and what are markers? Markers, if you can just recall it again, I repeat it. Markers are those kind of risk factors which indicate certain kind of probability of occurring certain disease, where it is not a causal factor. So attributable risk, when I calculating uh, incidence of people in exposed group minus incidence of the people, outcome in the non-exposed group. So whatever the percentage comes, we can say that this is the only percentage associated. This is the definitive percentage associated with the my exposure. Hence, I can say with confidence 70%. Say for the, if the exam score is 77%, out of 100 people, 77% has developed lung cancer due to the smoking. Other 23% might have developed due to some other reason that I have not studied. Able to understand it? Okay. Let's come to the population attributable risk. This is not so much done in our clinical psychological studies, but still, I'll try to explain this. Let's understand the interpretation of it so that it will be easier to grasp it. Let's understand the interpretation. Say for the population attributable risk is 70%. The interpretation is that if I if I modify the risk factor from the population, say for if I remove the smoking entirely from the population, so 70% of annual reduction of lung cancer will happen in the population. This is basically, I'm giving a definitive answer in a percentage manner. If a certain risk factor is removed from the population, then how much percentage of annual reduction of that disease will happen in the entire population. If the score is 70, then we can say 70% will be a percent of lung cancer will be completely reduced from this population. If smoking is reduced, the 70% lung cancer will be completely eliminated. So this is might sound little complicated, but again, as I told, this will require a little bit of reading on your part. It will be easy to understand. Risk factor, as I told, say if the result will be 1, then it has no association. Exposure has no association with the outcome. There is no association. If the risk ratio is more than 1, then that is possibly causal in nature. If the risk factor is less than 1, we can say that is a protective factor, as per the calculation, as I told. What is the interpretation of the risk ratio? What times the individual having exposed to a particular condition chances is there will have certain outcome as comparison to those individual who has not developed that condition. If it is 1, then can say there is no association. If more than 1, then can say that exposure that we have studied have a high association to give that outcome. If it is less than 1, then we can say there is a negative association, or that may be possibly protective factor. Let's come to the retrospective cohort study. Say for example, as clearly you can see from the results, is that one of the disadvantage of the prospective cohort study that it is a time taking in nature. Somebody has to wait for a long years. Somebody has to invest a lot of money. Somebody has to do a lot of follow-up to all the individuals. So it might be very difficult in that scenario to follow all kind of cases for a sufficient period of a time. For example, me being a researcher, I'm having a certain topic that my guide is very interested, but I know my PhD is only for 3 years. I won't have more than 3 years, and within the 3 years, within the 2 years, I have to submit, or 2.5 years, I have to complete my thesis. There I have to do the entire study, and I don't have a time for waiting for 10 years to see the outcome. And secondly, I do not have any funding, so I am doing it a very low stipend, so I cannot invest so much money of studying this factor. So what I can do, instead of going for a retrospective study, I can go a instead of going a prospective study, I can go a retrospective study. We'll take the same example of smoking and lung cancer. Here, what I'll do, now I'm in 2021. Try to understand. Now I'm at present in 2021. So basically, I'll go back in the time. Since 2006, I'll see various kind of data in the hospital records, or various kind of other kind of records that is available to me, other kind of scenario that is available to me, other kind of records that is available to me. From there, I'll try to divide the groups into peoples, those who are exposed and those who are non-exposed to smoking. So for example, when it's in hospital, the people are coming, we're recording something in the history, what substance they're taking, what the substance are not taking. So similarly, if I'm having that record, so I can go back into the history, 2006 in the record wise. From there, I'll divide. Say for 2006, these people are exposed, these people are not exposed. From there onwards, I can follow till present. Out of them, how many people in the exposed group have lung cancer or do not have lung cancer in exposure group. Similarly, I can also in the non-exposure group or reference group, I can see how many people do have developed a certain outcome, how many have certain lung cancer, how many of them, and how many of them are not having the lung cancer. And I can do this comparison. But here the point, the difference is that again, retrospective study is also known as follow-up study. Why? Now I am going back in the time, not in the time machine, by the records. I'm analyzing the records and seeing the records from 2006 to onwards. From there on, I am trying to follow the patients in a systematic way through the records, whether they're having certain lung cancer or not. How this can be done? The one important point is that when I'm giving the time, I'm selecting the time that of division of this group, exposure and non-exposure. One thing I have to be sure that point of time they should not have the outcome. In 2006, in this both the groups, none of the group, individuals should not have lung cancer at that point of the time. Otherwise, that is not, they won't be included in the sample. And that is no point of studying to those individuals. And why this is easy to do retrospective study? Basically, retrospective study, what happens in the retrospective study is that we take the information that has already been collected, which might have been collected for some other purposes, not necessarily related to the study that we are doing. They have been collected for some other purposes, and we are going and taking certain permissions from them, and we are collecting it. Say, for example, coming back to the example of this meditative practices and academic achievement. So what I can do, I can go to certain kind of meditation center, maybe Vipassana meditation center or some kind of meditation center. I'll ask them, so please, if they provide me, can you give the list of people who came here for 2000 meditation courses? You have attended your courses and they have done attending very systematically for a certain period of a time. So they can just share the information. They can share the information 10 years back onwards. Since, say, for example, it's 2021, they can give you information in 2010, this number of people attended our course. So at that point of the time, well, I need to be sure about certain kind of academic achievement, whether that thing is there or not. Again, that can be done only by the questionnaires or interviews, whatever way I can do. And from that point of the time till 2021, I'll try to see their academic scores or professional score or whatever the outcome that I'm interested in, that I'll try to follow. Similarly, I'll do with the people who are not exposed to the meditation. So in a way, the basic advantages is that this is time saving in nature and it's more efficient for studying long latency diseases. As I told, the more the disease will take time to develop, and cohort study, prospective cohort study will have to wait for that. But in retrospective study, obviously, the time taken for this study is only as most of the records will be available to you, or you have to only do the analysis over there. That is will be the time taken. So here, long latency disease also can be very studied. And obviously here you also calculate kind of relative risk. Now let's come to the kind of, ambispective cohort study. This is nothing but a combination of prospective cohort study and retrospective cohort study. What happened in the prospective cohort study? We, from today onwards, we were following the individual for certain period of a time in the future. In retrospective study, again, we seeing certain kind of exposure or non-exposed people. From there, we are studying till the present time. In ambispective study, for example, we'll use the meditation and professional achievement. From 2006, I got the records from some kind of meditation center. I followed the people to the present time. From again, I am also interested to see, okay, not only academic achievement, I want to say the professional achievement. I want to say that how they're doing in midlives, and there is some 45 or 50 years. From here also, they can see in the future. So that is nothing but an ambispective cohort study. It's a combination of both. But again, the important thing is that in whatever the exposure, cohort study is there, we are following from exposure to outcome. So first we are giving a reference, this, defining this is exposure. And when we're selecting the exposure, that point of the time, outcome has not to be there in any kind of the group. From the exposure, we are trying to see whether outcome is happening or not. Then we're comparing for relative risk, attributable risk, or population attributable risk. Let's come to the case control study. What is it? See, from there in the cohort study, the point of selection was exposure. From exposure, we're going to the outcome. It may be retrospective, it may be prospective. In case control study, what happens is that we select the cases and our control group as per the status of the outcome. Say, for example, at present 2021, we'll go to a certain hospital, we'll see how many people do have certain lung cancers. Then we make another group who do not have a lung cancers. Two groups will be done. One is case group, other is the control group. Then what I'll do is that from there onwards, I'll go back in the time. How I'll go? Similarly, I ask through various interview questionnaires or various kind of, I'll give the questionnaires to them. I'll do certain kind of interviews, or I'll analyze certain kind of record that is already available in the hospital. 15 years back, I'll try to know whether those people have been exposed, whether they have exposure of that substance or not. Similarly, in the control group, same thing, I'll be doing it. So from here, from outcome to I'm going to the exposure. The first point of selection is on the basis of the outcome. Those people having certain disease. Second group, those people do not have certain disease. From there, I'm interested to see, well, I'll ask through the various questionnaires and various kind of interview, I'll ask them from this 10 years, 15 years back, whether they have started smoking or they were not started smoking. From there onwards, systematically, I'll try to collect the information. This is the case control studies. Again, what is the advantage of the case control studies? Studies that are rare in nature. The diseases which are rare in nature. In cohort study, again, as I told, the more the diseases are rare, the more number of samples you have to take. And creating huge number of samples is always going to be a challenging task. But in the case control studies, mostly it's very much available at present in most of the hospitals that will go. What interested we are, sufficient number of cases are available. So if the studies are rare, case control study is the best method to do over there if you want to know the exposure status there or not. Again, this is also can be done for long latency period. In the prospective cohort study, you are waiting for 15, 20, 25 years as per the latency period of certain condition. You want to know academical achievement? Say, for example, in the, marshmallow study, that wait for 15, 20 years to see the effects in the academic achievement, marital achievement of due to the nature of delayed gratification. Those who are having self-control, how beneficial is that? So wait for 15, 20 years. But here, in the case control studies, we are selecting the cases as per the outcome only. And from the outcome, we are going retrospectively to see the things, whether the exposure was there or not. Then we compare the similar fashion as we do comparison in the cohort study. But what is the disadvantages there? The biggest disadvantages in the case control study is the recall bias. What happens, it's very common for the individual. It's very, very common for the individual. If they know their outcome status, they will recall the information related to the exposure in a different way. They will analyze the habits, they will analyze their lifestyle, they'll analyze their certain changes their in past experiences. They'll analyze it differently as comparison to the individual who is not having that outcome. We as an individual, we are very kind of people who always try to see the cause and effect. So we have a certain effect, we'll try to give a responsible thing in our past. Well, due to that, this might have happened. So sometimes that might be an exaggeration, sometimes that might be an over-reporting, sometimes that might be under-reporting. So it's not unusual for the people, to analyze the things in a very differently, which is very much seen in the abusive experiences. Related, sometimes it is very overly reported, sometimes it's underly reported. So this recall bias is a very much problem in the case control study. But since the cases are available in front of us, hence it is very much well establishedly done. But recall bias is something inherently there in all case control studies. But remember, one thing I need to tell, mostly we will read that case control studies are only retrospective in nature. Certain case control study can be also prospective in nature. Discussion of that, it is might be a little bit more. So maybe it's a latter point of the time I'll explaining how the case control also can be prospective in nature. But yes, mostly when you say case control, basically it is retrospective in nature. Basically, mostly we mean that. Okay, so we have to do very, as for the cohort study, similarly, how we'll select certain cases, how we'll determine certain cases, obviously we'll follow the criteria. What criteria of, say for example, academic achievement I want to see, I want to take those people who have high academic achievement. What is exactly criteria of academic achievement? So I have to be very objectively clear there. Certain disease, what criteria I'm going to follow. Disease criteria are well explainable in terms of if you're taking psychological diseases, ICD-10 criteria is there. But if you're telling any kind of other health condition, say quality of life, happiness, you have to be very sure. What do you mean by happiness? What do you mean quality of life? What things you need to operationally define? If these things are there, then you will say that they're having this case or they're not having this. This has to be very sure on that. So the selection of cases can be done in two ways. Either it is from population or either it is done from a hospital. Obviously, those cases were selected from the hospital. That is a population-based study. This is great for generalization of results. If we are selecting cases from the population directly, obviously, generalization, external validity is more stronger. But that might be very difficult to do, and that might involve lot of statistics, lot of sampling and sophistication. So hence, in most scenario, hospital-based study we mostly do, or institutional, if not hospital, institutional-based study. So we're selecting certain cases from the hospitals only. So yes, there's two ways. One is population-based study, that is more appreciable but less followed. Hospital-based study is morely followed because that is highly convenient for us to get a certain cases. Selection of controls. See, the most serious challenge in the case control study is a selection of the control. Who are my controls? And this is where people do a lot of blunder. At least we in our master days might have done many blunder related to it. Most serious challenge. See, it's better to select from the same hospital or population where the cases were selected. Say, for example, if I am selecting cases from a certain hospital the control has to be there from the same hospital. If not same hospital, I mean the population belonging from the hospital. It may be different hospitals. One from one government medical college, I'm taking certain cases, controller from another government medical college. If one from the same hospital, it can be done, or some other hospitals can be done. If I'm selecting cases from the population, the control has to be from the population. That is the best way. Why it has to be done? The simple answer is that, see, what we're trying to see here is the exposure status there. Again, so hence, whatever the controls we are selecting, the case and the control has to be equal in all respects. There has to be equal in all respects. Say, for example, I am doing now certain population of social anxiety, or say, for example, say depression in certain individuals. Then cases I am selecting from from a hospital, and the control has selected from PG students. So their demographics might quite differ, their educational background might quite differ, their economic status may quite differ. So all these things, so whatever the results I'm getting, that may be due to the background variables, that may be due to the extraneous variables. Hence, it's better to select the cases from the same source. Say, for example, another important thing we have to do, say for case, we are taking case of schizophrenia, we're doing certain study of schizophrenia or anxiety disorder from a hospital. And from there, who can be the controls? Any other individual who are admitted in the same hospital suffering from another conditions, maybe from orthopedic ward, maybe some kind of skin ward, it may be some other kind of ward. That is a good control for them. Otherwise, family members of the cases, it may be their relatives or whatever who are attending, or relatives of other patients who are admitted for different conditions. That also can be the controls, provided we are matching in all other stuff. The basic stuff is that we are assuming that the background variables would be same. But what happened in most scenarios, that cases are actually what, when we are selecting, might be with many of us, we did certain blunder. When you're selecting cases that is from the hospital control, we are given to any people, to even my batchmates. I just fill up this form, I need to complete my dissertation, I need to complete my thesis. You just fill up this form. That is kind of a blunder. Lot of background variables might be different, so that thing have to be especially taken consideration. Yes, what is the ratio? The better ratio is to take, if one is case, 2 has to be controlled. The maximum, if one is case, 4 has to be controlled. The more number of controls are there, better the statistical power it is there. So there is no point to have more than 4 controls per one case. 1:2 is a desirable, 1:4, that is obviously very good, not more than that. So what is the measure of association related to the case control study? See, the measure of association related to the cohort study that we did is relative risk. Here it is the odds ratio. Same kind of interpretation, but what happens in the case control study, the point of we are selecting cases on our own criteria. We are, we selected the cases, one group, and in other group there is no cases. Hence, you are not able to calculate the incidence here. In the cohort study, what naturally it is happening, how many people are developing the condition in the future, that will give you more, that is a true reflection of incidence. But here, the selection is done by the researcher. Hence, we're not able to calculate the incidences here. So, since we're not able to calculate incidence here, so what we are trying to do, we are trying to estimate the relative risk. And relative risk is nothing but is a calculation of 2 incidences. Since we're not able to calculate incidence, so we are estimating the relative risk here. Hence, it is known as estimated relative risk. Not only relative risk, it's the odds ratio is the estimated relative risk. Formula wise, yes, we can go about this formula, and the interpretation will be same as we did in the, if it is 1, no association between exposure and outcome. If more than 1, the score, then obviously it is exposure has something to do with the outcome, but here we'll say this outcome has something to do with that exposure. If less than 1, then odds of developing might be protective factor. So this is interpretation wise, it is more or less the same stuff. But here we are estimating the relative risk. We're not able to calculate incidence. As I told, cross-sectional study. In all the forms in the cohort study, from exposure to outcome we are going. And in the case control, from outcome, we are going to the exposure. The point of selection is the outcome. Then we're going to the exposure in the case control study. But in the cross-sectional studies, there is no such temporal sequences. I do not know here what we used to do. We used to simultaneously study the exposure and outcome. Say, for example, social anxiety, an association of stress in the students' population. I do not know whether stress came first or social anxiety came first, but I'm measuring both of it. So if a certain thing is exposure, is certain thing, I'll tell that is exposure. Hypothetically, it should come first. The lateral outcome will come. So in that, we are not able to calculate any kind of temporal sequences. Rather, we are measuring both exposure and outcome at the same point of the time. Hence, we know this is snaps. This is a photographic study. A snap kind of some term is there. I'm not able to recall. The simultaneous assessment of both exposure and outcome. This is basically what we do in a prevalence studies. And how it can be descriptive and how it can be analytic. Simple. If you're comparing with certain group with another individual, another group, then that will be analytical. And if you're not comparing, we're just able to find the prevalence, what is the kind of clinical picture, what is how much demographic distributions are there of OCD individuals. Say out of 100 patients, I'm talking OCD, I'm not comparing with any other phenomenon. So I'm doing only description, I can do. When I can say higher or lower, if there is certain description. So if you're not taking analytical group, then this is a descriptive cross-sectional study. If there is a comparative group, then we'd say it's an analytical cross-sectional study. And this is mostly kind of a design students used to do in their master's dissertations, all this stuff you'll see. It is easy availability of data, cost, time, benefits, everything is there. It's very easily done. But at a certain point of the time we're trying to collect the forms, we're going to appear in the individual. So not, we're not going forward back in the time. So easily you are able to do it. Okay, this is all about a kind of, related to the basics of observational research design. The next class will be talking about experimental research design, but here are certain reflections, questions. You try to find the answer to that. Which observational research design can document a temporal sequence of exposure and disease? Design mostly adapted for the study of prevalence. Which study? Which design mostly is adapted for the study of incidence? Observational design most suitable for study of prognosis. The direction of study from exposure to outcome is or are in which kind of designs? The direction of study from outcome to exposure is in which kind of designs? Empirical conviction in order of reliability. So which kind of design? Research design is considered to be highest empirical in nature. The measure of association suitable for case control study, whether that is relative risk, whether that's odds ratio or what. Risk ratio can be calculated in which observational research design. So this is the answer related to it. The next class will be going about the experimental design. Okay, till now, I'll just end my presentation. Okay. Yes, the part is